Thank you, Kara. At the outset, I would like to thank Mr. Narayan Prasad for inviting me to speak on the topic. Before I go to the pertinent questions in thrombotic microangiopathy, what thrombotic microangiopathy is important. Kidney failure or kidney injury is sine qua non for the presence of thrombotic microangiopathy. So for the diagnosis of thrombotic microangiopathy with or without microangiopathic hemolytic anemia. Microangiopathic hemolytic anemia is intravascular hemolytic anemia along with thrombocytopenia. Intravascular hemolytic anemia is diagnosed by the presence of fragmented RBCs, or what you call schistozoids, on peripheral smear examination, increased LDH levels, and low haptoglobin levels. Many a times we do not have all the three investigations, so you could use either two of them to make the diagnosis of microangiopathic hemolytic anemia. What are the questions pertinent to the topic? The first one is the current classification, a comprehensive classification for thrombotic microangiopathy. Two, what is the role of alternate complement cascade in health and disease and in thrombotic microangiopathy? The third, what are the genetic or the functional abnormalities in a patients with thrombotic microangiopathy? The four, what is the role of autoantibodies in the pathophysiology and diagnosis of thrombotic microangiopathy? You all would have seen reports of CFHR deletion or duplication. What is the role of CFHRs in the diagnosis and pathogenesis of thrombotic microangiopathy? Last but not least, you all seen patients with IgA nephropathy, patients with C3 glomerulopathy, or other glomerular disease with thrombotic microangiopathy. What is the significance of this? Is there a complement dysregulation in these patients? And then, what is the role of alternate pathway dysregulation in patients with malignant hypertension? So, before we go on to the classification part, there are many limitations to thrombotic microangiopathic diagnosis. The first among them is lack of awareness. What the mind does not know, the eyes don't see. So if you do not know microangiopathic hemolytic anemia, you are less likely to evaluate for the same. Non-availability of investigation is a real issue. Most of the folks sitting here have an easy accessibility to haptoglobin and LDH levels or a peripheral smear examination, but they can be constraints in limited resource setting. Even in abundant resource setting, peripheral smear examination is very poorly done because most of the time the technician or the resident will have to see 100 smears, and if you do not provide them with adequate data, they are likely to miss them or not see properly. The third one is delayed presentation to nephrologist. Many a times the microangiopathic is transient phenomenon, especially in patients with pregnancy-related HUS, where the thrombotic microangiopathy is very transient unless you carefully look into it. The fourth one is reluctant to biopsy a patient of acute kidney injury or carry out a contrast CT in someone who we suspect a cortical necrosis, which is nothing but an extreme form of thrombotic microangiopathy. The current classification of thrombotic microangiopathy is largely as primary and secondary. Primary, thrombotic thrombocytopenic purpura, complement-mediated thrombotic microangiopathy, and STEC HUS. And secondary, you have drugs, malignancy, transplant-related bone marrow, and kidney transplant-related. So what are the limitations to the current classification? First is on the pathogenesis. We have moved from a pattern-based classification to a pathogenesis-based classification. The classical examples are membranoproliferative glomerulonephritis, where we classify them as immune complex or as C3 glomerulopathy. Membranous nephropathy, where we have graduated to a molecular typing, where we classify them as PLA2R, NEL, and even NEL, it's complementary medicine related or malignancy related, semaphorins and exostosins for autoimmune related membranous nephropathy. Similarly, the classification of thrombotic microangiopathy does not reflect the pathogenesis like it should. Second one, the complement is the elephant in the room, and that the classification does not reflect the same. Like you have C3 glomerulopathy, but in the TMA classification, the role of complement is not reflected. Third, triggers. So maybe 1/4 of the patients sitting in this hall may have a genetic predisposition to develop thrombotic microangiopathy, and the triggers are the more critical ones, like hemorrhage, infection, pregnancy, some kind of surgical stress. So the triggers are critical, and classification should reflect them because they are very important in the pathophysiology of the disease. Then there is emerging anti-complement therapy. Outside eculizumab, there are at least 3 anti-complement therapies which are being evaluated, 2 at least in India, iptacopan and other C5e inhibitor. So I think the response to them also should be reflected in the diagnosis. This part may not be very relevant to Indian population as of now, but I think in the future is bright, and this should reflect upon in the classification. Coming to pathology of the TMA, I think my predecessor did a wonderful job by showing all of them in a single in a single patient. The TMA is not a single diagnosis, but it's a spectrum. It moves from endothelial swelling or endotheliosis till renal cortical necrosis. So endothelial swelling is nothing but swelling of the endothelial cells. Most common cause of endothelial swelling, you all know, is preeclampsia. Preeclampsia is a disease of the endothelium, and then becomes, if it is very severe, it becomes a disease of the podocyte. Second, mesangiolisis. Mesangiolisis, there is lysis of the mesangium. Again, most commonly seen in patients with snake bites. Then the third one is presence of fibrin thrombi, subendothelial widening, which you can see in the fourth figure towards your right. And then you have fibrinoid necrosis in the form of fibrin and subendothelial swelling, and the bloodless glomeruli, or what one may call as glomerular paralysis. That is just a step prior to renal cortical necrosis. So coming to the next question is the role of the alternate complement pathway in health and disease. There are at least 3 pathways: classical pathway, lectin pathway, and alternate complement cascade. The classical pathway and the lectin pathway are only activated if there is a presence of immune complex or any infection or presence of any liposaccharides, whereas the alternate pathway of the complement cascade is always activated. It is in a state of activation. It's also called tick off. The C3 is a very unstable molecule, undergoes spontaneous hydrolysis, resulting in the formation of C3H2O. Factor B in the presence of propyridine is broken down to BB and BA. The hydrolytic C3 along with factor BB results in the formation of C3H2O-BB, which is also known as C3 convertase in the fluid space, which is unstable. What the unstable C3 convertase does is it breaks down the C3 again into C3A and C3B. The C3B along with BB results in the formation of a stable C3 convertase. The stable C3 convertase along with BB results in the formation of C5 convertase. I'm not going to pronounce that because it's a very inconvenient pronunciation. So what the C5 convertase does is it breaks down the C5 into C5A and C5B, and C5B translocates to the surface of the cells. C5A along with C6 to 8 results in the formation of C5B8, which polymerizes C9 on the surface, resulting in the formation of C5B9, which is also known as membrane attack complex. The membrane attack complex is not a molecule, but it's just a channel which is formed in the surface of the cell. This channel is open and there is free flow of electrolytes irrespective of the gradient, resulting in hemolysis or lysis of the cell. So this is how a pathogen is being destroyed. But this can happen to even a normal cell, and that can be suicidal. So how is that regulated? Here comes the role of complement factor H. So the complement factor H is a glycoprotein which has 20 short consensus repeat. That is, each short consensus repeat consists of about 60 amino acids. The one towards your left is the amino terminal, and one towards your right is the carboxy terminal. The carboxy terminal of the complement factor H actually binds to the surface. That is why when you have a deficiency or an anomaly at the carboxy terminal end, you have thrombotic microangiopathy, because thrombotic microangiopathy is a disease of endothelium. Whereas if you have defects in the amino terminal end, which actually binds to the plasma C3b, you have C3 glomerulopathy and other related disease. Although it's not mathematics, it's more of a biology. So you could have vice versa also, but that's an exception. So what the factor H does is, the factor H actually binds to the C3b and prevents binding of other C3b to a single C3b which is attached to the surface, thus inhibiting the formation of the C3 convertase. Also, the blood factor H acts as a complement, as a cofactor for complement factor I. What complement factor I does is it prevents the joining of C3b and BB. Hence, there is no formation of C3 convertase. So this is what is being inhibited by complement factor H. So next is, what are the genes which are implicated in thrombotic microangiopathy? You have complement-related genes and non-complement genes. Among the complement-related genes, you could have a gain of function mutations. A gain of function mutations is with complement C3 or factor B. Loss of function is its complement factor H, complement factor I, membrane cofactor protein, and the CFHRs. Among the non-complement, DGKE is results in thrombotic microangiopathy in neonates and infants. It is non-complement related. It activates the coagulation cascade and VEGF dependent, VEGF inhibition, resulting in thrombotic microangiopathy. We had TREX1 related thrombotic microangiopathy recently reported. It is usually causes retinal vasculopathy and cerebral TMA, but it's also repeated recently with renal TMAs, and most of the time they are limited to the kidneys. Thrombospondylin role is highly debatable. There was a publication in 2009 in New England Journal. To cut the long story short, it is an amazing biology and a poor genetics. What they found was thrombospondylin is also found in normal population. Coming to the evidence on what is the percentage of patients with TMA with complement genetic defects, about two-thirds, 60 to 70% of the patients with TMA have genetic defects. The most common among them is mutations or aberrations or variations in the complement factor H, followed by membrane cofactor protein, C3, and complement factor I. Most of the data on thrombotic microangiopathy is from Europe, so much so that the Americans believed that it's only a disease of the Europe till eculizumab was available. So there's another study. The first one is from Paris. The second one is from Italy, where 16% of the patients had mutations in complement factor H, 7% with membrane cofactor protein, and C3 and CFI, and 4 and 3% respectively. Coming to another interesting, which the case was just present, the role of autoantibodies in complement-mediated thrombotic microangiopathy. We all now know the structure of the complement factor H. So you can develop, or autoantibodies to complement factor H is the most common cause of HUS or complement-mediated thrombotic microangiopathy in children. So about 55% of the Indian children with complement-mediated HUS or TMA have anti-CFH antibodies. Most of the anti-CFH antibodies, that is 93 to 100% of them, are towards the short consensus repeat 18, 19, and 20. That is 93 to 100% of them are towards the carboxy terminal, and that is why you develop HUS. And most of these antibodies are IgG3 in nature. Coming to the C3 glomerulopathy, 52% of them have autoantibodies towards the amino terminal end, and 47% or 48% have autoantibodies towards the carboxy terminal end. And as shown in the previous case, CFHR1 and 3 deletion is associated with complement factor H autoantibody associated TMA. The exact mechanism why these mutations result, or these variations or deletions result in thrombotic on production of anti-CFH antibody, remains unknown. There are also reports which have gone on to show that these deletions are also associated CFI antibodies. patients with anti-CFH antibodies have predisposing features like respiratory tract infection or diarrhea in 7 to 10% of them. Another antibody is anti-complementar 5 anti-complement I antibodies, which is seen in 33% of patients with complement-mediated TMA. This was reported by Dr. Kara herself. And most of these patients are tiny. If I remember, they were all less than a year. The median age was 10 months. And many of these patients have nephrotic range proteinuria. Coming to the mechanism of D plus HUS, it's most common cause of TMA less than 10 years of age associated with E. coli O157H7 or Shigella dysentery. It is because of the Shiga toxin 2 binding to GB3 receptors on the endothelium and activating the complement cascade, activating the coagulation cascade. And another important aspect is an emerging evidence that this may be complement related. If you see, the plasma of these patients is rich in complement factor B and membrane attack complex. And also there is a deposition of C3 and C5b9 in the kidney biopsy of these patients. There was a recent randomized trial which evaluated eculizumab versus supportive care in 100 of these patients. What they found was the primary outcome of RRT requirement was no different between both the groups, although numerically better in the eculizumab group, but presence of urinary abnormalities or chronic kidney disease was better with eculizumab as compared to the control, and the difference was statistically significant. So the bottom line is in D plus HUS, there are functional abnormalities, but there are no genetic abnormalities to suggest complement activations. So what are the tests that you will do? I'm sure that my successor will speak about these. So genetic testing, I just attended the KDIGO meeting being a member, and what was decided was to do a whole exome sequencing targeting only the complement genes. If it is negative, they would evaluate outside the complement genes, or you could do a targeted sequencing of complement factor 3, C3, B, CFH, CFI, and the CFHRs, and you do a multiplex ligation probe amplification to see for copy number variation. There is duplication or deletion of CFH and CFHR 135. So next is coming to the functional testing. Functional testing is important. So there's a laundry list of tests, but what I believe is what are important is you either do alternate pathway functional assay or AH50. C3, C4 I think is freely available. Then you do C5b9 assessment, which has got a therapeutic implication. If a patient is on eculizumab and having a non-CFH related TMA, you can also withdraw eculizumab if the patient is in stable remission and for presence of autoantibodies against CFH and CFI. So what are the things that one need to be mindful of? There are at least 3 lessons that I learned. One is the complement proteins are highly unstable and you need to immediately put them on the ice. If you keep them on an ambient temperature, there will be activation of complement and very high levels of C5b9. We lost close to 100 samples this way. The second thing is ADAM-TS is very important. You start your workup with ADAM-TS testing. I didn't focus because that's largely a domain of the hematologist. And we had a patient who was on a clinical trial. We found the lab from the country showed normal levels, and finally, when the results came from an internationally validated lab, the patient actually had TTB. The patient had CNS manifestations along with kidney injury. So it was a case of TTB. The third one is genetic testing is very important. You need to be very careful when you do genetic testing. There's a competition, so people are likely to cut corners because they want to get as cheap as possible. So we had 2/3 of the patients with pregnancy associated HUS showing duplication CFHR 1 and 3. Many of these patients were planned for transplant. So we actually sent these samples to David Kavanga for validation because it was surprising to us. And what we found was none of the reports were validated. They were all wrong reports. It was probably the control that the company was using probably had only one strand, and all the duplication, all the normal were shown as duplications. So you need to be careful. You need to have an access to the raw data of these patients. Coming to the last part is the significance of CFHRs. CFHR is very common in normal population. There was a publication in PLOS One, which actually, I'll take 2 minutes more. So there's a publication in PLOS One which actually evaluated the role of CFHR in population. What they found, which also had a Gujarati Indian population, and they found that 38% of the population were positive actually for CFHR deletion, homozygous or heterozygous, heterozygous being more commoner than the homozygous. And there was a study by Dragon Dury in 2009 where she reported the frequency of CFHR deletion homozygous was commoner in patients with HUS. However, when anti-CFH and anti-CFI related HUS were expunged, they found that there was no difference. So the role of CFHR deletion is largely debatable, but I wouldn't stop there. I think we should look at the functional abnormalities. There may be a novel finding. There are at least 3 reports that I have seen. One is CFHR deletion in patients with pregnancy-associated TMA, which was reported from Pune by Dr. Valentin Lobo. Another case of HUS, which was a hybrid between CFH and CFHR1, which caused TMA from Pune, and the similar one caused familial C3 glomerulopathy in a family, which is under our follow-up now. So the last part is about the secondary TMA. I'm running over time. So, this is a study which evaluated up 300 patients, half of them with AHUS or TTP, and half of them with secondary glomerular disease, which was stem cell transplant, organ transplant, malignant hypertension, other glomerular disease. The main was clinical outcomes and the genetic results. The clinical outcome showed that those patients with secondary TMA had poorer prognosis compared to those patients with AHUS or TTP. Coming to the genetic testing, 2/3 of the patients were positive for rare genetic variants with AHUS, and 15% were positive for secondary TMA. Whereas when they looked at pathogenic or likely pathogenic, 49% were positive for AHUS and 3% were positive for secondary TMA. So it goes on to suggest that the secondary TMA, there is no much role of complement activation. However, there is another study, so there can be a debate, is presence of TMA, complement-mediated TMA in malignant hypertension. This study was published in 2018, actually published in 2017, where they reported that less than 50% of the patients with renal limited TMA actually had, with malignant hypertension, had renal limited TMA. And the TMA was mainly in the form of endothelial swelling, fibrin thrombi, and intimal edema. And all of these patients had elevated C5b9, that is the membrane attack complex. And 2/3 of these patients, that is 6 out of the 9 patients, had positive genetic testing. 3 had positive for C3, 1 each had for complement factor H, I, and membrane attack complex. So I think there is some role of complement in malignant hypertension, but not in other secondary diseases. So my last slide is a summary. So there is a role of alternate pathway dysregulation in patients with complement mediated TMA. Genetics is positive in 60% of the patients with complement-mediated TMA, and the most common one is variations in CFH gene. The role of CFHR is debatable, and we need to read more, or we need to evaluate more. The third one, anti-CFH TMA, most common cause of complement-mediated TMA in children and associated with homozygous deletion in CFHR 1 and 3. In STEC-HUS, there is an emerging role of complement, mostly functional rather than genetic. Then malignant hypertension, where you have ruled out all the other causes like IgA, C3, and other glomerular diseases. And most of these patients present with renal limited TMA, and alternate pathway dysregulation is found in 100% of these patients, with genetics in 2/3 of these patients. Thank you all for a patient hearing.